Welcome everyone to Tecno webinar. I'm Sarah Mahgoub, brand manager in Tecno Pharmaceuticals. Tecno is the first Egyptian company specialized in female hormones. It has a wide portfolio of female products like Fimogezal, Norgestadiol, Marteviva, Tecnospirone, and Progest. Tecno core values are availability, affordability, and quality to ensure that every female can have an easy access to the medication she wants with a very high quality. Our webinar today will be Contraception and Infertility, the two sides for the same coin. And our moderator will be Professor Hassan Salem. It's an honor, Professor Hassan, having you today as our moderator. Professor Hassan Salem is a professor in obstetrics and gynecology and the chairman of the Egyptian Representative Committee of the Royal College of Obstetrics and Gynecology. You're all welcome here today, and the Professor Hassan will be our moderator. The mic is all yours, Professor Hassan.
Ladies and gentlemen, welcome to today's webinar entitled Contraception and Fertility, the Two Sides of the Coin. I want to start by welcoming you all and thanking Tecno Pharmaceutical for sponsoring this webinar. And it is really a great pleasure for me to present our two eminent speakers today. I want to start by introducing Dr. Ali Kuba. Professor Kuba is the lead consultant in colposcopy and reproductive health care at Guy's and St. Thomas's hospitals, two of the most famous hospitals in the United Kingdom. This is where the Prime Minister of the UK was admitted when he had his corona. He's also a board member of the European Society of Gynecology and the vice president of the European Society of Contraception and Reproductive Health. Professor Ali is very well known in the international arena for his work in the field on contraception and women's health in general. And today, we will be very pleased to hear him talk to us about Tecnospirone, a novel contraceptive option for the modern woman. Professor Ali.
Thank you.
The floor is yours.
Okay, thank you very much. Thank you, Professor Hassan Salam, for the introduction, and I'm really delighted and honored to be part of this webinar. My thanks to Tecno for looking after us very well. My presentation is going to be on Tecnospirone, and I've titled it Novel Contraceptive Option for the Modern Woman. I'm going to give a talk for about 30-35 minutes, and they'll answer questions. If you have questions, you can put them in the Q&A, and they would be answered. Just identify yourself and say where you are from when you put the question. It will be quite helpful. I work in London. I've worked in London for a long time, and I use sometimes images in my presentation. So this is Big Ben. St. Thomas's Hospital is just at the end of Westminster Bridge, so it's just around here. That's why our Prime Minister just drove across the bridge when he wanted to go into hospital with COVID. I also work at the London Bridge Hospital, which is on the other side, about a mile away, in this tall building called the Shard, which is currently the tallest building in Europe. This is my email if you want to email me. These are my disclosures, and I use this slide to salute all the health healthcare heroes who have looked after us so well during the COVID crisis. And I hope that this will clear, and maybe we will see you live in Cairo or in Alexandria sometime in the future. My presentation is going to be in 3 parts. They're mixed slightly together. Combined oral contraceptives, I'm going to look at the many benefits and at the few risks and put them in balance. I'm going to talk about Drostperinone, the features and advantages, because this is an innovation in contraception. I'm going to look at the life course approach. I'll show a couple of slides looking at where the pill as a contraceptive option sits with a young person, a person who's facing their family, and a person over the age of 40, and look at the possible therapeutic uses of the pill. I'm going to I have a lot of slides, so I'm going to run through some of the slides fast, but the slides will be if the meeting is recorded, and you can always go back to them. Access to contraception is a matter of life and death. The more access women have to contraception, it is very clear, and this is across the world, the greater reduction in maternal deaths. This is from the Lancet a few years back, showing that as contraceptive prevalence increases from 20 to 40 to 60%, you have an increase in the savings in the life of women. So you get a 60% reduction in maternal mortality with a 60% contraceptive prevalence. So this is a business which is important for public health and for us, for the family, for society. When we talk about contraception, we look at the ideal contraceptive. I put here a picture. This is a painting, very famous painting by Bouchard, French artist, called The Swing, Irregular. And it looks at the promise of life. You know, these are 2 lovers meeting, just sort of making contact with each other. This is actually in a place called the Wallace Collection, which is in the center of London. If you come to London, you go to Oxford Street to shop. This is just behind the shops in Oxford Street. It's a beautiful, beautiful painting. So what is the ideal contraceptive for this young couple? Well, they want contraception to be 100% effective. They want it to be safe and it doesn't have side effects. They want to make sure that if they stop the contraception to have a baby, to try their fertility, that is reversible. It's easy to use, not complicated, does not interfere with intercourse, accessible and cheap in the sense it's affordable, and makes both partners feel responsible for contraception. Obviously, an ideal contraceptive is yet to be discovered, but I think for a lot of women, the pill could be the ideal contraceptive for many. And indeed, this is Time magazine in 2010. The pill has been around now for over 60 years. And in that issue of Time magazine, they said probably one of the most important inventions of the 20th century. Many people think it was, the pill, the most important invention of the 20th century. Pill use worldwide varies, and this is the use in Europe. It's in it's a bit small. So this is the oral contraceptive, and you can see that there is a range. If you look at the UK, about 26% of women use the pill. This is a study from about 10 years ago, and I think it is now a bit lower because there has been a shift in the UK to using intrauterine contraception. And let us compare this to Egypt. And as a matter of fact, it is quite similar. This is 2018-19, so it's very recent. And obviously, the intrauterine device is the top method in a lot of the Middle Eastern countries. But the pill has a respectable following. And it means that women actually want a method they can control, a method they think is good for their bodies in certain aspects. And what we want to do is to make sure that women have the facts, evidence-based medicine. They have facts rather than myths, so that they use the pill being very reassured about its safety and its value. I think intrauterine contraception is ideal for women in low-income and middle-income countries, but we have to remember that for the cheaper device, which is the copper intrauterine device, there is an issue around heavier menses and heavy menstrual bleeding. And anemia is endemic in the Arab world. And therefore, we need to make sure that we're not increasing that risk to the women. The pill, on the other hand, as I will show you, will save women from that point of view. And of course, women want a method which is effective. And this slide shows you the two ways we express failure. We talk about perfect use failure, the green columns, and you can see with the pill, if used properly and consistently, you're looking at a failure rate of 3 in 1,000, which is as good as any other method. But obviously, if we don't teach the woman how to use it, if the woman is anxious and stops the pill first time she has a problem, the failure rate is higher. So we need to try to focus on counseling and good advice so that we improve the efficacy of the method. What is the impact of the pill on the public health, on health? I'm just going to show you two slides, just really as a way of visually showing what happens. This was defeated in Europe, and you can see that the pill use increased from 1990. By 2003, there were about 1 million users of the pill in the Czech Republic. See what happened to something else. This is ectopic pregnancies in the Czech Republic, starting from the year where the pill use was very low to 2003, and you can see this drop in ectopic pregnancies. This happened against the background of opening up of sexual expression and therefore probably an increase in sexually transmitted infections. A 37% reduction in ectopic pregnancy, one of the benefits of the pill. And I want to use it as a way into looking at other benefits. Look at pelvic inflammatory disease in women who use the pill. These are several studies, the references are here. All of them show a reduction of about 50%. In all of them, the reduction is highly, highly statistically significant. Let us look at gynecological cancer. And again, you will see that in the two big cohort studies from the UK, this is a study from the Royal College of General Practitioners, has more than 1 million women years. This is the Oxford study, as it is called now, has about 750,000 women years. It shows that there is a reduction, anything like 40 to 70% in cancer of the endometrium, similar reduction in ovarian cancer, in cervical cancer. These two studies also look at breast cancer, and I'll talk about breast cancer later. But notice that in these two very large cohort studies, there does not seem to be an increased risk in breast cancer. So this is where I talk about the many benefits and the few risks. To just expand, this is the 2017 update, the last update on this 1 million women's years study, showing that in this cohort, there was a 20% reduction in colon cancer. This is now a fact. You can say that to the woman. And overall, over a lifetime, there is a reduction in endometrial ovarian cancer. And this study, for the first time, showed a reduction in leukemia. But we don't use this to counsel women because we don't have further evidence about it. It needs to be proven in other studies. Let us look at fibroids. Again, a lot of people think the pill stimulates fibroid growth, but you have to remember that the net effect of the pill on the uterus is a progestogenic effect, and therefore you can see there is a substantial reduction in fibroids in women using the pill. So this is a summary. The pill is very good for preventing a pregnancy if used appropriately, and therefore reduces the comorbidities that happen in pregnancy, ectopic pregnancy, or miscarriages, but also has a number of very important non-contraceptive benefits. So there is a shift in the perception of women as far as what they want from the pill. They wanted, in the old days, they wanted a method which is very effective. They know that if they use the pill properly, it is very effective. So their concern is about side effects, tolerability, is about, does this pill help my skin and hair? Is concern about weight gain, and also convenience. Can I go get it? Is it available? Is it affordable? Can I buy it? So we need to address that change in emphasis from women. And I want to look at the life course. So I want to look at the young couple probably before their first baby, before they plan fertility. The anxiety here is that the pill may affect fertility. The answer to this is that the pill preserves fertility. We're going to have a talk about fertility after this. So the message is the pill preserves fertility. Look at the woman who's spacing children. Now, obviously, immediately after birth, you can't use the pill because of the fact that there is a higher risk of venous thromboembolism. But the guidelines in the UK have actually changed. We now, after 6 weeks from birth, we are allowing women, even if they are breastfeeding, to use the combined pill. And you can refer to the college and to the Faculty of Sexual and Reproductive Health for further evidence on that. And of course, for the woman over the age of 40, you want a method that addresses her needs. And I'm going to show you some slides to address all 3 stages in a woman's life. But let us just look who can use the pill. And the message here is that nearly all women can use combined oral contraceptive safely and effectively, including those who have not yet had children. No effect on fertility. Even teenagers. Now, obviously, in the Arab world, we probably would not be considering contraception for teenagers unless they are married. We discourage adolescent pregnancies. But in this group, the pill is perfectly safe, doesn't affect the HPO axis, and I'm going to show you a slide on this. After a miscarriage, again, as long as there were no complications with the miscarriage, the pill can be used. Obviously, smoking is bad news for the woman from all kinds of parameters. But we have to remember that if smoking was a single risk factor in a woman under the age of 35, you may allow to use the pill. It's what we call a class 2 rather than a class 3 indication. Anemia is important. A lot of people say, I can't use this medicine, which is a hormone, because I'm anemic. Actually, it's the other way around. If you use it, you reduce bleeding, and therefore you will probably improve your hemoglobin and your ferritin levels. And though venous thromboembolism is a known risk with the pill, varicose veins are not contraindications. So for young people, we have issues around fertility, which we've addressed. Birth defects, if someone takes the pill and they fall pregnant and they don't know about it, the risk is exceedingly small as far as that. And I'm going to address all the other aspects. It doesn't stunt growth. As long as menarche has been established, there is no effect on growth as such. People say damages the body. Well, it has a number of very important benefits, which actually make it a plus rather than a minus. And I'm going to talk about the other issues. So for a young couple who are just married, who may want to have a baby in a year or 18 months, well, it's an appropriate method. All the professional organizations say that. It causes less pelvic inflammatory disease, so it's good for fertility. And because it causes less menorrhagia, less dysmenorrhea, you have fewer surgical interventions, and therefore complications that may affect the fertility of the woman do not happen in these cases. Return of fertility has been studied in a number of studies. This is the active surveillance study of oral contraception, showing that the ability to fall pregnant is as good as if a woman was not using the pill. It's 46% within 3 months. What about the woman at the other end of the age spectrum? So this is Barbie, if you don't recognize her. This is when Barbie is, as you know, now is about 65 years old, but this is when she was about 45. Now, what does a woman at the age of 45 want from a contraceptive? She wants the contraceptive to be very effective because pregnancy is a real risk. Obviously, the combined pill, if appropriate in this age group, is extremely effective, nearly 100%. They want something that will relieve menopausal symptoms. And obviously, if they're taking an estrogen, they will not get menopausal symptoms. And they will enter their menopause with better bones as well. It may not be preserving or increasing the bone density, but it preserves bone density. They want something to be gynecologically protective, reduces heavy menstrual bleeding, less risk of fibroids, less risk of endometriosis, and indeed it does that. And they want it to be free from medical risks. That is not a feature of the pill, but you need to assess the woman to make sure that she has no risk factors. The pill is safe. There are some women who are dangerous, and you need to pick up the small number of dangerous women and give them something else. So I said I'll talk about breast cancer, and the analyses are different. I've just shown you studies which don't show an increase. There are studies, and these are the studies there, but there are studies which show an increase of something like 23%. 23% is actually, in relative terms, you think, 23%, that's a massive increase. This is from the collaborative group on hormonal factors and breast cancer. But if you look at the absolute risk, what is the risk to the woman? So the woman says, okay, 23%, what does it mean to me? It means an excess risk, an additional risk of under 0.5%. And the woman can then think about it and say, it's all right, I'm not too worried about it. And of course, the pill reduces the risk of benign breast disease, fibroadenomas. And you can see a number of studies which show a statistically significant reduction. And this is the last slide on risk. So people talk about myocardial infarction and stroke. Women who have no risk factors, this is extremely rare. And as a matter of fact, there is some evidence that pills that have modern progestogen, such as Drostperinone, may actually be neutral. They don't increase that risk as such. And of course, we need to talk about the other factors. Breast cancer, we've talked about. Cervical cancer, area of controversy. The increased risk depends on sexual behavior. I want to talk about venous thromboembolism. So I'm going to use a graphic. So this is a picture. And those of you who enjoyed the movies in the 60s and 70s will recognize that this is Audrey Hepburn, who is one of my favorite actresses. This is in Breakfast at Tiffany's, her famous film. And you can see the picture is made of people. Now, if you imagine that this group is 10,000 women, okay? Now, in a year, this year, these 10,000 women, 4.5 will have venous thrombosis. So it is that person, that person, that person, and that person. If they go on the pill, 9.5. So you add this group as well. If they are pregnant, you're talking about 30 in 10,000. So it is the whole of this. So pregnancy and the purpurium is always a risk factor. Now, some people say if you're using Drostperinone, it may have a slightly higher risk of thrombosis than the traditional norethisterone levonorgestrel pills. Well, if there is controversy, and there is definitely no statistically significant difference. But if there was a risk, then you're looking at this 9.5 going probably to 11 or 12. So people say that's a 50% increase or 30% increase. In numbers, it's fairly small. It's still just that little group there. So I think we can reassure them by giving them absolute rather than relative risk. And indeed, in the UK, for instance, the Medicine Control Agency says the risk of venous thrombosis with Drostperinone is very small. And this was a statement in 2011. And no excess risk if only starters are considered. So if a woman comes and says, this is the first pill I'm using, there doesn't seem to be an increased risk. It's when you have a problem of someone who's already had problems with oral contraception that you notice there is an issue. I'm not going to talk about putting the risk in perspective. You can look at it. So this is an interesting slide from the chief medical officer in the UK from about 20 years ago, but still relevant. This is Drostperinone, and you can see in the studies that have been done comparing Drostperinone with levonorgestrel, which is supposed to be the safest progestogen from venous thrombosis, or with other oral contraceptives, or by combining levonorgestrel and other oral contraceptives. You can see that all these cross the line, cross the unity, which means there is no statistically significant difference in venous thrombosis between Drostperinone containing pills such as Tecnospirone and other oral contraceptives. And indeed, you can see this in the table here. And if you look at Drostperinone, that is 9.3, as I've just pointed out, per 10,000, there is an overlap. If you compare this to levonorgestrel, which is 7.5, this is the 2 in 10,000 that I've talked to you about. So we can be reassured about the safety of this product. And of course, we have to think about obesity and smoking and actually talk to the woman about reducing her own risks of getting thrombosis rather than the other way around. Now, let us look at the modern woman and what they want. We said that they want a method which is effective, a method that is safe, a method that they like. That is important. They need to have people. I see a lot of European women because I work in central London, and they come and say, I like my pill. And you want the woman in Cairo or Alexandria or anywhere else in the Arab world to say, I like my pill. And we have to give them clear information, and we have to stress these added value, the therapeutic indications. And why do we need a new pill? Why do we need an innovation such as a Drostperinone containing pill? Because there is worry about weight gain, about many of the symptoms that come around period time, breast tenderness, mood changes, nausea, and intermenstrual spotting. So we will look now at where new pills, these novel contraceptives, fit in. This is obviously just a summary of what I've said, which is the benefits. So we talked about mineral density, we've talked about regular cycle, we've talked about cancers and fibroids. These are the therapeutic indications: treatment of acne, treatment of hirsutism, premenstrual syndrome, menorrhagia, and dysmenorrhea, and indeed endometriosis. So what are the features of Drostperinone? Well, it's different from any other progestogen because it's a derivative of 17-alpha spironolactone. So it has anti-mineralocorticoid effects. That is a mild but important feature because it does reduce water retention. And a lot of women who come and say, I can't put my wedding ring in, is because they have water retention in their fingers, and very close to natural progesterone. So they have this natriuretic effect, similar to those of mild sodium-reduced diet. It's equivalent to a very small dose of spironolactone. So if you want to think of it in this way, that is a reasonable way. It's also an anti-androgen. So it blocks the androgen receptor, which means testosterone, which is produced by the ovary, doesn't express itself as well. So it has this dual advantage. Now, some people say, spironolactone, could that affect potassium? It doesn't. The effect is too small for it to do so. And it is a 21 pill packet with 3 milligrams of Drostperinone, which is micronized, and ethinyl estradiol, again micronized at 30 micrograms. So quite an attractive packet. I like the logo that is here for Tecno. And of course, this is where Drostperinone fits. It's as you know, the first generation progestogens, the norethistron, levonorgestrel, are effective and good, but they have androgenic effects. The third generation progestogens, desogestrel, gestine, norgestimate, still have androgenic effects, but they are much milder than the androgenic effects of the older pills, and therefore they have less side effects. But with Drostperinone and Dynogest, we have pills that are much better tolerated because they are anti-androgenic rather than weakly androgenic. And this is the idea with fourth generation progestogens. And this is just a depiction of where things fit. So you can see that, levonorgestrel, norgestimate, they're all derived from the male hormone, from C19 nortestosterone. Drostperinone is the only progestogen which is a spironolactone derivative. And it is very similar to progesterone with good progestogenic activity. So it's good for heavy menstrual bleeding because it's a potent progestogen. It has no androgenic activity. It has anti-androgenic activity. And among the progestogens, it's the only one that has anti-mineralocorticoid similar to progesterone. So these are the important advantages. And the reason why we think this is important is the issue around weight gain. Now, women can gain weight in a number of ways. Water retention is one. The effect of progestogen causing relaxation of muscle, for instance, which causes bloating, is another, and a metabolic change as well. So an oral contraceptive that reduces the incidence of weight gain could have potential to decrease the incidence of pill discontinuation. And I'm going to show you a very important slide. So this is a really, really important slide. This is comparing a desogestrel pill, the blue, with Tecnospirone, the red. What do you notice? So this is a year. This is month 26 of follow-up. The difference in weight between the two is statistically significant. The important thing about this is you notice that in the first 1, 2, 3, 4, 5, 6, 7, up to about 9 months, the weight is not affected in the Drostperinone group and the Tecnospirone group. And this is the time when you give a pill to someone and they come 3 months later and say, this is not the pill for me. I've put on weight. This is the situation you notice here. By the 4th month, it's starting to go up. In some women, it will go up even quicker. So it buys you time to allow the woman, as I say, to love her pill, to actually, in a way, enjoy using an oral contraceptive. And how does it do it? Is because, again, it blocks the aldosterone receptor and therefore reduces water retention. And we said it's equal to 25 milligrams of spironolactone. So in a way, this allows the woman to have a stable body weight, so she doesn't have to change her skirt size. And there's also the effect on menstruation, less menstrual complaints and pain during these critical times just before and during the period itself. Let's look at one aspect of premenstrual problems that happen and are very important worldwide, which is premenstrual syndrome or premenstrual tension. Now, all women with menstrual cycles will experience some changes around the period. About 90% will say, well, there is a change, my mood changes, I get pain, but maybe tolerable. About 20 to 40% have premenstrual syndrome, and about 4% have the severe form of premenstrual syndrome, which is actually a life-threatening condition. I used to run, I've stopped running it now because I've changed my profile, but I used to run a premenstrual tension clinic, and I sometimes get families. Once I get a family, a man, a woman, and their son was about 16, and he said, you know, I'm really worried about my dad because my mom, for 2 days during or 3 days during the month, she sort of gets a kitchen knife and she's running after my father, trying to sort of, you know, stab him. And that's PMDD. So it is an important entity for us to understand. And indeed, this is a work that is already published in the Egyptian Journal of Psychiatry, showing that the general PMS is actually common. And we know it is because women come with it. And I think we ignore it. We need to focus on it because it is about the mental well-being of the woman. And there is massive emphasis at the moment in the UK, in Europe, about the mental aspects of menstruation and how contraception affects the mental aspects of menstruation. And you can see that if you look at both physical, such as water retention, or mental effects, negative effect, feeling of well-being, that Drostperinone ethinyl estradiol, that is Tecnospirone, actually causes a reduction in the problems of all of these. And this is statistically significant for water retention, statistically significant for feeling of well-being. I need to just speed up. So this another way of looking at the general well-being index, and you can see that there is actually a bit of a cumulative effect. So the general score statistically significant from placebo, but it increases with time. So it's always worthwhile carrying on, encouraging the woman to carry on with the pill to definitely to 6 cycles to appreciate the full impact. And we have evidence. So there is evidence from our college. So this is from the Green Top Guideline 2007, when treating women with PMS, newer contraceptive pill types represent effective treatment and should be considered first line. Sean O'Brien, who is the god of premenstrual tension in the UK, says the choice of oral contraception in PMS, ethinyl estradiol Drostperinone. This was published in the BMJ and was supported by the Cochrane Systematic Review. So it is evidence-based practice that we're talking about, this sort of split personality as this image shows. What about the skin? Well, Drostperinone again is good for the skin. We know that low androgenic pills, we're talking about gestodine, desogestrel, are good, but anti-androgenic pills treat acne and make the skin better. And they also have a role in polycystic ovaries. So they regulate the cycle, they prevent endometrial hyperplasia, they treat these skin effects, and also provide contraception. And that is a sort of all-in-one. And how do they do it? Is because, again, Drostperinone blocks the androgen receptor. And among the progestogens, it's Drostperinone which competitively displaces androgen in the receptor, blocking the androgen action in target organs. Of course, like other pills, it increases SHBG, and therefore it mops up testosterone as well. And this, again, is showing, if you look at the cyproterone acetate, this is Diane-35 or Diane-8, which has a very potent anti-androgen. You can see that actually the purple columns, which are Tecnospirone, actually have an effect which is quite similar to Diane, especially in inflammatory type acne. So it has a therapeutic role. What about bleeding and the pill in general? This is just a slide to remind you that 6% of women will, at any time while taking the pill, will say, this pill is causing the problems because they're having intracyclic bleeding. But I'm not going to stay too long on this. Let us look at how the pill works for dysfunctional bleeding. And you can see here in this study, which is an RCT, that if you look at the investigator, 81% said yes, it actually reduces bleeding. If you look at the patient, 87% say my periods are much better, and the difference between this and placebo is statistically significant. Cycle control with Tecnospirone is quite good. So over half patients report no intermenstrual bleeding. So you've got a good bet that the person has over 50% chance of not having any problems. But I just want you to see what happens by month 3. If you look at the cycle 3, you'll see that the intracyclic bleeding is becoming around 6%. And actually with this pill reduces even further. So month 5, 6, 7, you're looking at a very slow rate of irregular bleeding. So you can reassure the woman from the convenience point of view of not being surprised by having abnormal bleeding. Spotting and amenorrhea observed in 1, 9.3, 3.2 of all cycles respectively. So to summarize, why do we need a new combined oral contraceptive with Drostperinone? This is the combination. It works very well. It's a potent progesterone, is good ovulation inhibitor, and therefore it's good contraceptive. 91 to 99% success rate in the first year, and therefore it's effective if it's used properly. So we need to teach the woman to like it, to trust it, and to use it properly. The cycle control is, as I've just shown you, it is a therapy for premenstrual syndrome. You need to give it time. So we talk about cycle 6, both for the physical aspect, water retention, and for the mental health and well-being aspect, and increases overall psychological well-being. So I tend to say pills that do well, one, give the woman this tranquility and elegance. This is Henri Matisse. I absolutely love this painting because it shows, it actually reminds me, my aunt used to have a pullover very similar to this. And it is where a woman is settled and is happy with her method of contraception. But it also affects the family. The title of my slide is Men Like Good Pills. Why? Because the women are happy. They're bleeding less. They have less problems with premenstrual tension. They look better because of their skin. They don't complain of water retention. And they have all the other benefits, the prevention in ovarian cancer, the reduction in endometrial cancer. So this is a British slide saying the man, the woman, the baby, if they have a baby, and the dog are all happy because the family is doing well. So I think we have to make contraception a happy experience. We need to be positive. We need to address the needs of the woman, give her proper advice, help her to use a method effectively. And I'm really pleased that you are here. I'm the Vice President of the European Society of Contraception. This is my slide to say that in September next year, we will have our 16th Congress in the beautiful city of Ghent. So if you like chocolate, it's there. If you like beer, it's there. If you like culture, it's there. And I would be delighted if many of you attend. And as a matter of fact, we had a webinar for the society earlier this week, and I saw that there were over 10 people who registered in the seminar. So thank you very much, and thank you for listening. And I apologize to Hassan because I took a bit longer, which is a problem for me.
Thank you very much, Professor Ali. This was a beautiful presentation, and I think everybody is happy, including the audience. And indeed, we have quite a few questions from the audience for following this beautiful presentation.
Okay.
Now, the first question comes from Dr. Mohammed Sheikh, and it is about the relation between breast cancer and can we use it definitely, and how about duration of use and time of use? I think also he's asking about the starting, should we start on day 1 or day 5, or does it make any difference? And then about the breast cancer issue.
Okay, so let's do easy one is day 1 to day 5. The faculty guidance and now the American College and the European Society also agrees that if a woman starts a contraceptive up to day 5, so day 1, 2, 3, 4, give them a bit of, don't be very strict, give them a choice. So it doesn't have to be the Sunday if they can't do it on the Sunday. As long as they do it in the first 5 days, it works immediately. So they do not need to use extra precautions. Obviously, if someone, for instance, had a failure with a method of contraception in the past, ask them to start on day 1. As far as breast cancer is concerned, I'm going to just very quickly mention a few things. One, a woman with breast cancer cannot use the pill, cannot use hormones. So that is done. A woman with a family history of breast cancer is actually okay to use the pill. There is no, her risk may be higher, but the pill doesn't make the risk even higher. So you're okay from that point of view. Someone using the pill with breast cancer and their risk of breast cancer, the risk is quite small. It is in the region of about 2, probably 3 in 1,000. So if their risk is, let's say, 4%, it goes to 4.03. So in an absolute sense, the risk is actually quite small. The longer she uses it, there is some evidence that that risk does increase. Remember, breast cancer risk increases with age as well. So that's number 2. Number 3, when she stops the pill, within the first 5 years, up to 5 years, there may still be some risk, but it drops down and becomes nil between 5 and 10 years. So there is, in a way, no cumulative effect. So a woman says, "Ooh, I'm really worried about breast cancer because my mother had it when she was 48. I'm now 28. If I use it now for, let's say, 2 or 3 years, am I at a greater risk when I reach the age of my mother?" And the answer is no. There is no cumulative effect. So we can be reassuring, but that doesn't mean that we are irresponsible. So if a woman has a certain risk, then we need to be very careful about.
Thank you very much, Professor Ali. There's another question from Dr. Nazih Heikel. It concerns the menstrual breakthrough bleeding. And the question is, is it effective in preventing both pre and post premenstrual bleeding? And whether this also, again, has a relation between the day of starting. I mean, if people start on day one, does this diminish the incidence of intermenstrual bleeding?
Yeah. Okay, so we'll answer this last one earlier. No, there is no difference if they start on day 1 or day 5. That's number one. Because we don't actually understand why people get intracyclic bleeding. We don't understand the mechanism. It's probably more a molecular effect at the level of the endometrium. We know that in the first few months, there would be a higher risk. And we know that in general, about 6% of cycles have intermenstrual bleeding. So for, the points about that the woman needs to be aware of, this does not mean that there is, because a lot of women think there's something wrong with me. This pill is interfering with my hormones, and that's why I'm bleeding in an irregular way. You reassure her that this is an end organ response. It's actually a false bleeding, which is due to the fact that she's on the pill. Doesn't mean that she's not well. It doesn't usually give her anemia because it tends to be light. So you can reassure her from that point of view. It does not impact on her fertility, and it does not mean that the pill is not working. These are the 4 points in counseling that are really important to impart to the women. What we do about it is another matter. And I missed one of the slides because I didn't really want to take too much time explaining things. We in the UK at the moment are telling women that if they want to use the pill all the time, because a lot of people come and say, okay, I want to use contraception, but I don't want to have a period. Why should I have a period? A lot of people are now very environmentally aware. My daughter, for instance, when she was a teenager, because we know that when they use sanitary protection, their pads, their tampons, these are non-biodegradable. Do you know that every year, billions of tons of sanitary products go to refill sites? So young people say, I don't want to increase the burden on the planet. If I can, I don't want a period. Is it safe? Definitely safe. So we tend to say that if you want to use the period all the time, obviously that will probably produce amenorrhea over a long period of time. So you can, in someone, for instance, who says, I don't know what's happening, I get my period, I also have 3 days of bleeding in the middle of the cycle, you can say it is safe to take the pill all the time. You might get some breakthrough bleeding, but at least you won't have 5 days at one end and 3 days at the other. You reduce the number of days of bleeding. And I think that is something that we need to just think about, is definitely what we are doing now in the UK.
Yeah, thank you very much. Does it have a relation with the body weight?
Well, so people have looked at the dilutional effect, and it could it be that there is a dilutional effect? There is some evidence that there may be a dilutional effect. As you know, there is evidence from using the contraceptive patch that women who are over 90 kilos in weight have lower efficacy with the contraceptive patch. But the problem is, if there is a dilutional effect, the natural thing to think about is to say, I'm going to increase the dose of the hormone. But if you have someone who's obese, you don't really want to increase the dose of hormone because it might increase the risk. So we have to accept that it happens, and we have to try to manage it. And in a way, this, what we call extended use, might actually do the trick. It doesn't expose the woman to massively large amount of hormone, but it keeps her cycle more stable.
Yes, we have another question from Dr. Nahla Ghorab. Can I use Tecnospirone safely in a patient with benign thyroid tumor with irregular cycles?
Well, so you need, obviously, if the tumor is not cancer, if it's cancerous, then you need to talk to the oncologist. But the interaction between the pill and thyroid disease is minimal. And therefore, my advice would be, yes, you can use it to control the cycle. If the cycle is controlled, I would say for any person with some sort of a endocrine disorder, you want to minimize the time they're using a hormonal method. And therefore, I would say a lot of women with problems with bleeding, they want to have a respite. If a woman comes and says, you know, shahr ba'ad shahr, month after month, I'm having these irregularities. If I can have 3-4 months where I'm okay, you know, I can predict my period, I can go, you know, to visit people and go to parties and whatever. So I would use it probably for 6 months, settle it, stop it, and it could be that the bleeding will be okay beyond that.
Yes, sir. Yeah. A question from Dr. Mahmoud Lutfi. What are the possibilities of hyperkalemia incidence while using Drostperinone?
Well, I mentioned it.
And on this, yeah.
Yeah, I mentioned it. It's none. So you don't need to worry about it. Everybody looked at it, and there does not seem to be a risk with hyperkalemia. The dose is too small. And as you know, Tecnospirone in the various types it is in the world has been used by millions. It's one of the most, advanced and sort of popular products that exist. So I think we can reassure people about hyperkalemia.
Yes, sir. Another question from Dr. Lutfi. Is it better to use Dino Gest or Drostperinone containing pill to treat androgen-related symptoms in women seeking contraception? Because as we know, pharmaceuticals, they have both compounds. They have the Mastaviva, and now they have the Tecnospirone.
So so in a way, Tecno have got the market from both ends. So which is always a good policy. The combinations are obviously different because, as you know, with Dynagest you have a estradiol valerate, which is a natural estrogen. I use that, for instance, for women who feel that they want something natural. That's number one. I use it for women maybe over the age of 40. But I think for Tecnospirone, the point about it is the weight effect. So while both Drostperinone and Dynagest are anti-androgens, it's only Drostperinone which is an anti-mineralocorticoid. So if you want to address that, and if you accept that many women, in my experience in the Arab world, are, they will go to the hairdresser or they go to their plastic surgeon or whatever, and their skin is usually good, they're worried about weight. And they worried about, do I fit in this new thing that, Nancy Agram is wearing or something like that. So it's very important that we address it. And I think, Tecnospirone does that. Yeah.
Yes, sir. Okay.
I'm not making an advert for Nancy Agram, obviously. I only listen to
Professor Salah he's happy because he's a
Can I make a comment, please?
Yes, please do. Please.
Okay.
Yeah.
Dr. Ali, I am very happy that Tecno invited you. Rarely it is the first time for me to hear you. And I feel that I lost a lot that I didn't hear to you before. Yes, I'm speaking really. Your presentation is more than spectacular. That's my personal opinion. So it's be sure that in any other presentation, I will be the first listener to you.
Yeah. Thank you very much. Thank you for that. Can I just first of all, Salah, I really want to thank you. I think visually, there are two reasons. One, I think a visual presentation, if you look at the slide that had Audrey Hepburn, it just highlights the absolute risk. It really is a very important thing. But there are some people say, some people will find any presentation boring. They can always look at the slides. And I'll tell you a joke. It may be sort of just bigging me up. I go to the Gulf quite a lot to give talks. And once I went there and I thought I need to be serious. I'm going to take all these images from my slides. And a lot of people in the audience says, what is this? We're here to look at the images that you use and how you talk about them. So that was one. The other joke, and this is a true joke, I sometimes, not now, when I was a bit younger, I used to do tours. So I will go in the UK, for instance, I'll go to Birmingham and then to Wolverhampton and to Coventry. These are cities in the Midlands. And I had a guy who came and said, like you, he said, I love your talk. I said, well, I'm giving a talk in 6 hours in the evening. He said, yes, I'm going. I said, but I'm giving the same talk. He said, yes, I know, but I like to watch your slides. This is crazy. But thank you very much for that comment.
Thank you very much. We have two more questions, if you don't mind, Professor Ali. Sure. You said something about the ectopic pregnancy, and that ectopic pregnancy is diminishing because with the pill compared to the coil with the intrauterine device. Do you think that this is because the intrauterine device protects the woman from intrauterine pregnancy, but not extrauterine pregnancy.
Yeah.
Is this
Well,
a right way of looking at it?
Well, I know. I think there are two things really to think about. It's obvious. The pill does not stops ovulation. If you don't have an egg, you won't have an ectopic pregnancy. That's one. An intrauterine device, a woman ovulates, and it will work in spite of ovulations. That's number one. Number two, the pill does reduce the risk of pelvic inflammatory disease. So it reduces the risk of salpingitis, and that may also help. But I need to be very clear that the intrauterine device, if you look at people using an IUD compared to people who use no contraception, the actual risk of ectopic pregnancy is lower. The problem with ectopic pregnancy intrauterine devices is the device is much better at preventing intrauterine pregnancies. It is not as good in preventing ectopic pregnancies because it's not working on the tube. So it is actually a false impression that the IUD is linked to. And to just, for people who are interested, if you look at Mirena, which is a progesterone IUD, you can see that Mirena has a lower risk of ectopic than the copper IUD. And we think because the hormone interferes with fertilization. So you get an egg, but you don't get. So there are stages in the risk.
Preventing. And the final one is about breastfeeding. You said something about breastfeeding, and the question is, does it come out in the milk? So
no. If it comes in the milk, I mean, the way people look at breastfeeding, and I've just had a grandson. He's only 5 months old, so I'm really thinking about. He's coming to visit me this weekend. So the quality of breast milk is not affected. And we know that all the milestones of a baby, when a baby walks, whether they get their teeth at the right time, whether their cognitive function there is absolutely no difference. Their weight is the same. Their development is the same. So we know from the outcome of how babies do in the first year, mind you, obviously, there are studies which look at a bit longer, but it's mainly the first year, there doesn't seem to be an impact. The reason why I mentioned breastfeeding is because currently, and I think it is probably what is the advice in Egypt, is to say, if a woman is breastfeeding, you don't use the combined pill either until she finishes or up to 6 months. That has changed. The Australians, forever, for years and years and years, have allowed the pill in their patients who are breastfeeding from 6 weeks. You can't use it in the first 6 weeks in a breastfeeding woman because of the risk of thrombosis, because mainly it's the first 3 weeks. But beyond that, so the Faculty of Sexual Reproductive Health a few years ago changed their guidance to say it is allowed. Obviously, you have to discuss it with the woman, but it is something that is allowed if someone is desperate, is familiar with the method, whatever, if there is access issues.
All right. But does it affect milk production or milk?
Shouldn't. No, it doesn't affect milk volume or doesn't stop the milk. So they say, my breast will dry up. There is no evidence to that.
Yes. Yeah. Thank you very much, Professor Ali, for the beautiful presentation, as always, and for the beautiful pictures from the Wallace collection, the Courtauld collection, and let alone the National Gallery. I used to live in London. I used to go to all these beautiful.
So I can see that you, Professor Hassan, have a appreciation of style and of the art. I mean, the Wallace collection is fantastic, and it's very easy to go. When you go, it's a small museum, so you just can walk, and it's free as well. So it's a good thing. I'm sorry, I have to go because I have patients booked, and I have to go and see my patients. So thank you very much. I'm really delighted to be part of this meeting, and thank you, Salah, for your very nice comments. Bye bye. Bye bye.
All right, ladies and gentlemen, we have been with Professor Ali, and now we are, it is my great pleasure and honor to introduce another top speaker, Professor Salah Rashid. Professor Salah Rashid, you probably know him. He's Professor of Obstetrics and Gynecology at Sohag University. He's the director of Ibn Sina IVF Center in Sohag. He is also the treasurer of the Egyptian Foundation for Reproductive Medicine and Embryology, EFRI, and he's a member of the executive board of the Diploma of Assisted Reproduction Birmingham, Dear Mas. Professor Salah is a great friend, and he is a great speaker, and it is my pleasure to introduce him. I also want to remind you that if you have any questions, please put them in the chat section, not in the Q&A section. Professor Salah, fadl.
Good afternoon for everybody, and many thanks for our Professor Hassan Salam for this kind introduction, and also we are very grateful for the pharmaceutical of Pharco for organizing this meeting. My presentation today is about the role of progesterone in reproduction. The following topics will be addressed in this presentation is about the role of progesterone in spontaneous cycles, in stimulated non-IVF cycles, in IVF cycles, and the role of progesterone for patients with miscarriage and for term labor. Let us to remember some of the physiology. All of us know that under the effect of LH, the follicular cells during the second half of the cycle undergo a process of morphologic and biochemical exchange, rendering it to progesterone instead of estrogen in preparation for the formation of the secretory endometrium. The corpus luteum and pregnancy live in a state of symbiosis, just to say that both are depending on each other. So a functioning corpus luteum is essential for implantation, and on the other hand, pregnancy is essential for corpus luteum survival. In other words, the generator of the corpus luteum is the LH. The promoter of the corpus luteum is the HCG. All of us know that the LH is released from the pituitary in boluses, and this is reflected in the progesterone release, which is the progesterone level shows a high magnitude of a fluctuation throughout the days in accordance with this LH release. This pulsatile release render it is somewhat difficult to set a value, a normal value for progesterone level in the second half of the cycle. Let us to illustrate what are the formulas of progesterone which are available in the Egyptian market. The progesterone is available in three forms, either synthetic, the micronized form of progesterone, like the Progest capsule 100 milligram of Tecno, and Tecno is very glad to announce its new product, which is 200 milligram. And according to my knowledge, it will be the micronized progesterone, which contains 200 milligrams. And I think this, for me personally, this type of progesterone will cause a breakthrough in the field of fertility treatment, because the 200 milligram will be highly convenient for the patient. So the patient can use one capsule instead of two, and it will be much more affordable. What about the pharmacokinetics of progesterone? The oral natural progesterone is impractical for use in reproduction because of its very fastly degraded and destroyed in the gastrointestinal tract, leading to it's just 10% of it will be bioavailable. Moreover, it has a teratogenic metabolite. About the oral synthetic, it's different from the oral natural. It's associated with higher bioavailability and a stronger affinity to receptors. However, the oral synthetic has many disadvantages. The first disadvantage is that none of these synthetics have identical effect to the natural progesterone. The second, they are associated with more side effects, mainly androgenic side effects. But the main shortcoming of the oral synthetics is that they have anti-ovulatory and luteolytic effects. This is applied to all types of oral synthetic. I mean, the last disadvantage, except the dydrogesterone, which does not have anti-ovulatory activity. In the mid-80s, appeared what's called the micronization of progesterone. The micronization it means increasing of the molecule of the progesterone, or of the size of the progesterone particle, and this micronization will increase its absorption from the gastrointestinal tract considerably, will avoid its gastrointestinal destruction, and will be associated with a longer half-time of progesterone. About the vaginal route of progesterone, it's the vaginal route when compared to the oral is associated with a more bioavailability of the drug and less side effects. Another advantage of the vaginal route is that the vaginal progesterone does not undergo a process of first bypass the liver, so it does not metabolize it into byproducts. And these byproducts may causes of the side effects, mainly the dizziness and the fatigability. So simply the vaginal route of administration of progesterone may avoid these side effects. On the other hand, the vaginal progesterone, instead of undergoing a process of first bypass in the liver, it undergoes it within the uterus. And this criteria is associated with higher uterine levels of despite a relatively lower serum level of the drug. And this illustration shows that after 1 hour of application of vaginal progesterone, nearly half of the uterus, including the cervix, is covered or is saturated with progesterone. 4 hours of application of the vaginal progesterone, the whole entire uterus is being saturated with progesterone. That's to say that the maximal effect of vaginal progesterone is reached after 4 hours of its usage. About the intramuscular, there is no doubt that the intramuscular progesterone was associated with the highest serum level, but on the other hand is associated with a relatively lower endometrial concentration when compared with the vaginal route. And the main limitation of the intramuscular injection, it may be somewhat non-convenient to many patients, and it may lead to irritation and abscess formation at the site of injection. About the subcutaneous progesterone, it has been claimed to be associated with lower dose necessary to achieve its action, and may be associated with less side effects when compared to the intramuscular route. That's to say, decrease the abscess formation at the site of injection. Now we are going to the first issue in this presentation, which is the role of progesterone in spontaneous and stimulated non-IVF site. There are great debates among the clinicians and the researchers about answering this question, whether the luteal phase defect, does it really exist or not? Actually, we have two groups. The opponents which deny the existence of luteal phase support, mainly the ASRM, which is stated in 2015 that the current clinical irrelevance of luteal phase defect, and its argument stemmed from the fact that luteal phase support, we don't have any reliable diagnostic test for diagnosing luteal phase deficiency. This is because of the, as mentioned before, the high fluctuation of the serum progesterone in the luteal phase will make it unsuitable diagnostic or invalid diagnostic test to diagnose the luteal phase defect. This was further validated by many researchers who concluded that there was no published evidence that support that the progesterone improves the pregnancy outcome, neither in a spontaneous cycle or nor in clomiphene citrate or letrozole stimulated cycles. On the other hand, the ASRM 2015 stated that or concluded that the progesterone improves the pregnancy rate after gonadotropin stimulation for non-IVF cycles. On the other side of the river, we have many proponents that luteal phase defect is a real problem and should be treated. And they have many arguments that firstly, no one can deny that the progesterone is absolutely required for implant, not only for implantation, but also for ongoing pregnancy. And they stated that the evidence is clear since about 50 years by this amazing experiment, where in experimental animal, removal of the corpus luteum was associated with abortion if it is done before 7 weeks of gestation. Not only that, but at that time, the pregnancy can be salvaged by the administration of progesterone. This observation indicates that the progesterone is mandatory for establishment of implantation and for continuation of pregnancy. If the removal of the corpus luteum was done more than 6 weeks of pregnancy, there will be no effect, because at that time, the placenta is forming, secreting HCG, which will support the corpus luteum and the ongoing pregnancy. And they have another argument. They stated that despite the barriers mentioned regarding the non-validity of a progesterone for diagnosing a luteal phase defect, yet the progesterone is up till now the only practical method to diagnose the luteal phase defects, and unfortunately we don't have any other way for diagnosing the luteal phase defect. That's to say, a practical way. And they add that in this context, or in women with a luteal phase defect, if the progesterone was administered, the risk of progesterone therapy is exceptionally very small, if any. And they added that the medicine is not only a science, but it is an art. Yes, the guidelines, the principles of the guidelines should be respected, but as stated by the Sir William Osler, medicine is a science of uncertainty, so that if you are certain that luteal phase deficiency is the cause of infertility, and it is an art of a probability. This may be a probability. And according to this all background, these authors recommended that suspected anyone with a clinical suspicion of luteal phase defect should be treated with progesterone. And they commented more that they acknowledge that the progesterone treatment in these patients is not evidence-based, but rooted from a clinical interpretation of the underlying pathophysiology of the luteal phase. And they commented more that pointing out to the opponents sticking the head in the sand does not actually work, because the many and the majority of clinicians and centers use progesterone for suspected luteal phase defect. If you want to use progesterone, please don't a dose which is more than 300 milligrams per day is unnecessary. This is, be sure that we are speaking about the spontaneous and stimulated non-IVF cycles. This is about the first topic. The second item in the presentation is about the role of progesterone for IVF cycles. And please let me to answer or to deal with this topic in a series of questions. The first question: which patient undergoing IVF should receive luteal phase support? It's generally agreed that luteal phase support should be done for all patients undergoing IVF. The stimulated cycle of IVF is completely different than the natural cycle. In IVF cycle, the very high level of estradiol will inhibit the corpus luteum function. In addition to that, both the GnRH agonist and antagonist have a suppressive effect upon the corpus luteum. So this first question is closed, and all patients should receive luteal phase support. The second question: what is the best drug for luteal phase support in these patients? Simply, progesterone is the ideal luteal phase support in cycles triggered with HCG. In cycles triggered with GnRH analog, the situation may be somewhat difficult, which will not be discussed in this context. So we should close this question. The third, please, we should take this illustration will validate why progesterone is very necessary in IVF cycles. Here, after the HCG injection, what's happened? The HCG will stimulate the corpus luteum directly, which releases the progesterone. The effect of HCG will last for a couple of days, about 6 or 7 days, then will fade away. And as the luteum is still suppressed by the high level of estradiol, then a period of time called as the luteal gap. During this gap, we don't have HCG, neither exogenous nor endogenous, produced by the trophoblast. Then after about 1 week, with the establishment of pregnancy, the trophoblast will release HCG, which will stimulate the corpus luteum again to release the progesterone. So it's just to say it's very important to add the progesterone for all patients undergoing IVF. The third question: what is the best route for using progesterone in these patients? Before answering this question, 2 issues should be addressed. The first: what is the optimal serum level necessary for implantation? The second: what is the serum level which is obtained after using the different routes? in order to select the best route. What is the normal, what is the optimal serum level of progesterone necessary for implant? It has been stated that during the early luteal phase, the minimum should be 18, and the minimum level of progesterone should be 18 nanogram per milliliter. But in the middle luteal phase, at least 50 nanogram per milliliter is necessary. Is to be this minimum threshold, both in the early and in the middle luteal phase, is not absolute, and some centers use a lower or even higher level than that reported in this figure. We should think about what's happening in the natural cycle. In the natural cycle, the progesterone, the ideal progesterone level in the early luteal phase, at least 6 nanograms. But in the middle luteal phase, at least it should be 25 nanograms. So, simply speaking, in the IVF cycles, we have at least double of these values, because in the IVF cycles, we have many different changes. We have menocorporal lutea, we have the supraphysiologic level of E2, which will suppress the corpus luteum function. This is the first issue. The second issue, what is the serum level which is obtained after the different routes of progesterone? If we discuss firstly the intramuscular progesterone, the 25 milligram per day is not associated with a satisfactory level, so it's excluded. The 25 milligram is not a suitable amount of progesterone for luteal phase support. The 15 milligram of intramuscular progesterone will provide a satisfactory level for about 7 or 8 hours maximally. The 100 milligram, actually the 100 milligram will lead to a very high level initially, which exceeds 800. Then it remains satisfactory for more than 12 hours. However, it should be stressed that this very high level may be not physiologic and may harm the process of implant. If we go to the subcutaneous progesterone, this study was done in 2015 and it is sponsored by the EFSA itself. The 24 milligram of subcutaneous progesterone will provide a satisfactory level for just 4 hours. After that 4 hours, the level of progesterone will decrease below what is necessary. The dose which will lead to a satisfactory level of progesterone is the 100 milligram of subcutaneous progesterone. The 100 milligram will give you a satisfactory level for 24 hours. Just to say, if you want to use the subcutaneous progesterone, the ideal dose is 4 ampoules per day. About the vaginal micronized progesterone, the main advantage is that it is targeted organ therapy because it undergoes a process of first bypass within the uterus, and so it's associated with a higher uterine level despite a comparatively low serum level. About the oral progesterone, actually we don't have data about the serum level of the progesterone as it is fastly converted after absorption to the active metabolite 20-alpha dihydrogenase. However, the evidence stated that oral progesterone, intramuscular, vaginal, subcutaneous progesterone all have a comparable live birth rate in women undergoing IVF. At that point, we cannot close this question. This question is still open for discussion, and we have a very important inquiry. Is oral progesterone really adequate for luteal phase support in IVF cycles? Actually, the answer was stemmed from the basic science The basic science is the root from which the applied science originates. What is the basic science state? In a very important study published in 2017 by the Belgian group guided by Professor Paul de Vroy, stated that oral progesterone does not induce adequate secretory changes, and it causes out of phase endometrium in more than 80% of patients. On the other hand, the clinical trials yielded completely different results, and we have many studies done in highly respectable centers and by prestigious researchers which concluded that the vaginal or intramuscular progesterone has no advantage over the oral progesterone in IVF cycle. In response to these studies, the HRE has no way, and it should respond to these studies and include it in its last mission, which is that oral progesterone is probably recommended for luteal phase support. And please put more than line under the word probably. And actually, many clinicians and researchers assume that progesterone might be a lifeless drug for patients undergoing IVF cycles because it is instituted through a process of persuasion. And persuasion means convincing the others when the facts does not seem to matter. And this has all these observations has been implemented on the ground, where the largest IVF survey done in 2018 about the use of the different progesterone route in the different IVF cycles, more than 3/4 of the IVF centers use the vaginal micronized progesterone, and only 1% of the centers and another 1% of the center uses oral or subcutaneous progesterone. So we should close this equation. If you want to use progesterone, you can use either the intramuscular or vaginal micronized progesterone. If you will select the vaginal route, what is the best vaginal preparations available? The last HRE guidelines says that all preparations have a similar clinical pregnancy rate, but a recent study which has been published in the Human Reproduction concluded that the micronized vaginal capsule is more preferable because it's associated with a more steady concentration of the serum progesterone, and this is probably attributed to the slower, it's somewhat slower rate of absorption when compared to the other forms. The second advantage, it is more convenient because it's not associated with the staining of the patient. And the last advantage, which has a very important concern, is associated with less bleeding episodes. And all of us know that the bleeding episodes after the embryo transfer is very annoying for the patient and also for the gynecology. If we have gone again to the survey, about 46 of the IVF centers using micronized vaginal capsules. The fourth question: what is the optimal amount which is necessary during IVF cycle? This table illustrates the different doses of the progesterone in IVF cycles, but now come a very important question: whether increasing the dose of progesterone is beneficial, or in other words, whether too high progesterone, I mean after embryo transfer, is good or bad. Although all of us agree that the ceiling concentration of progesterone is up till now not well settled. If we come again to this, the ceiling concentration is 30 in the luteal phase and 80 in the middle luteal phase. And this study raised a very surprising conclusion, which states that below these levels, below the 30 and below the 80, but most importantly, above these levels, the pregnancy rate is considerably low. And this has been validated in experimental study published in 2018, which stated that the high concentration of progesterone is harmful both for endometrial receptivity and for decidualization. So please don't, the high amount of progesterone is not only unnecessary, but it may be harmful to the process of implant. The fifth question, when to start the progesterone? Your main goal is to induce what's called embryo-endometrial synchronization. And many times have been proposed for a start of progesterone therapy, including the day of HCG, the day of oocyte pickup, 1 day after oocyte pickup, and even at the day of embryo transfer. But the last recommendation included that the progesterone can be given between the evening of the oocyte pickup till 3 days later. This is the best time. However, a recent meta-analysis found that the highest pregnancy rate was reported if progesterone was given 1 day after the oocyte pickup. If you want to use an intramuscular progesterone, this is applied to the vaginal micronized progesterone. If you want to use the intramuscular progesterone, it is preferable to use it at the time, at the day of oocyte pickup. Actually, this finding has no interpretation. This may be related to the relatively slower rate of absorption of the intramuscular progesterone when compared to the vaginal, so it is preferable to use it 1 day before. So we should close this question. The progesterone ideally is to be given 1 day after oocyte retrieval in cases of vaginal progesterone, and at the day of oocyte retrieval in cases of intramuscular progesterone. And this actually was true in the IVF survey, where about 45 of the centers due to progesterone on the day of oocyte pickup, and the other 41 day after the oocyte pick. The last question, which is a very controversial question, when to stop using progesterone. Similarly, many set points have been proposed, including the time of a positive pregnancy test, 3 weeks later, 5 weeks later, the moment of appearance of the fetal viability, 7 weeks later, and even 12 weeks later. Please, let us to learn from the nature, which is the best ever teacher. What the nature states. The nature states that the progesterone is kept in a spectacular state of idealistic homokinetic. What does it mean? This illustration, this amazing illustration, shows that during the first trimester of pregnancy, at the end of this first trimester, the progesterone level does not exceed 40 nanogram per milliliter. Not only that, at 8 weeks of gestation, the progesterone level decreases to reach the minimum level of 10 nanogram per milliliter, then gradually increase till the end of the first trimester. Moreover, and taking into consideration that the serum, the native serum HCG, is more potent and has different isoforms when compared to the commercialized HCG. What does it mean? It means that everybody would need an extra amount of progesterone. With the establishment of pregnancy, it could easily and competently output it. But the body does not need this extra amount of progesterone. It needs only this amount of progesterone, which is highly dedicated and highly ultra titrated. And according to these backgrounds, The last recommendation states that a progesterone supplementation is unnecessary after the first positive pregnancy test. And this has been validated in many meta-analyses and many systematic reviews. This issue has been discussed for about 10 years ago when Professor George Griesinger of Lopek stated that whether it is a time or put an inquiry, whether it is time to abandon progesterone supplementation during the early pregnancy after IVF. All of us know that the field of IVF has many pressures, both for the clinician and for the patients, including social, financial, and psychological pressure. So, in answering this question, we should group the stick from the middle, or we should reach a compromise between the scientific findings and the pressure on the gynecologist and the patient. And this compromise has been described about 20 years ago by Professor Klaus Dietrich of Germany, who stated that we can stop progesterone after 3 weeks of embryo transfer, just to say 5 weeks of gestation. And why that time? Because at that time, the effect of both GnRH agonists and antagonists on the corpus luteum is completely ablated, and at that time, the trophoblastic HCG dominate. So we should close this question. We should stop progesterone at the time of a positive pregnancy test or maximally 1 week later. What's happening around us regarding this conclusion? Unfortunately, about 1/3 of the IVF centers continue progesterone till 12 weeks of pregnancy. And only 14% of the IVF centers discontinue progesterone at 4 weeks, that's to say at the time of a positive pregnancy test. Then this attitude of the IVF centers didn't change throughout 10 years. Between the old survey in 2009 and the recent survey in 2018. Then come a very important question regarding the progesterone support in IVF, whether an evidence-based medicine was translated to a clinical practice or not. Unfortunately, the answer is not. The clinical evidence was not the evidence base was not translated to a clinical evidence. We should ask ourselves why. What are the reasons behind this discrepancy? It was stated by Professor Douglas and the JAMA in 2015. The reasons is due to non-medical reasons. The first reason behind the discrepancy is using what's called the dictum of Peter saves than sorry. This is the ancestral Spanish statement. It means that Peter said if the pregnancy didn't continue, the gynecologist will say for the patient, it's out of my hand, I did everything, and you are even using progesterone till the end of the first trimester and the pregnancy didn't continue. Then saying, oh, sorry, I am sorry, it's not, it was not correct to discontinue progesterone early, and in the second pregnancy, it's better to continue progesterone till a longer duration. The second reason, and I say unfortunate reason, is the lack of confidence in implementing the guidelines of the best available evidence. A third reason has been stated by Professor Fleming in 2013. Many gynecologists stated that it may be true that progesterone is better to be discontinued early, but this trust is inconvenient to them. And they added that the trust is clear, but it may have many faces. But in this context, we should apply the immortal statement by the famous political Winston Churchill, who stated that if trust is multifaceted, so the lie will be polyphonic. Another reason stated by Professor Hans Eber stated that many clinicians and many IVF centers state that, yes, I know the evidence, but I don't care. We have closed the issue of the role of progesterone in IVF cycles. We are going to the third or fourth item, the role of progesterone for miscarriage. We have two types of miscarriage, either spontaneous, either threatened miscarriage or recurrent pregnancy. The last recommendation of the ASRM about the use of progesterone in the threatened early miscarriage, it states that progesterone actually have no role, or we don't have a strong evidence of which supports the use of progesterone in these ladies. However, in women who have seen recurrent early pregnancy loss, the use of progesterone will be beneficial to these patients if it is used during the first trimester. We have a very important and very large studies, which are the promise and the premise study, which has been conducted in one center. The promise study, it means the role of progesterone in women with recurrent miscarriage. It was a randomized trial published in the New England Journal of Medicine. The dose of progesterone which is used was 40 milligrams of micronized vaginal progesterone. The early conclusion of the promise is that progesterone didn't increase the live birth rate in women with recurrent early miscarriage. The PRISM study, progesterone for spontaneous or threatened miscarriage, also using a 40 milligram of micronized vaginal progesterone. The conclusion, the early conclusion of the PRISM was that progesterone didn't increase the live birth rate in women with a threatened miscarriage. However, in a further subgroup analysis of these two studies published by the same authors in the current years, they concluded that subgroup analysis, if it is after doing it, so the patient will get benefit of progesterone therapy. And here is the result of the PROMISE study. If a woman have previous to abortion, she will get benefit of progesterone supplementation. But the highest benefit of progesterone supplementation will be gained if the woman have 3 or more previous consecutive early miscarriage. About the result of the PRISM study, nearly the same finding. The highest beneficial effect of progesterone was obtained if the woman has a previous 3 miscarriage, and now she is coming in a state of a threatened abortion. About the live birth rate after a PROMISE and the PRISM trial, after subgroup analysis, the live birth rate is increased after progesterone use in women with 2 or 3 more consecutive early miscarriage. This table shows the results of all published studies about the role of progesterone in women with women with recurrent pregnancy loss. Nearly the vast majority of the studies showed a beneficial effect of vaginal micronized progesterone in women with history of recurrent miscarriage. The last item in this presentation is the role of progesterone for preterm labor. One of the most famous studies, which has been published in the Lancet in 2016, is the Optimum study. Its main conclusion is clear that the use of vaginal progesterone was not associated with decreased risk of preterm labor. However, the last NICE recommendations in the last year stated that prophylactic vaginal progesterone is beneficial in women with a spontaneous history of preterm labor, or if screening revealed cervical length of less than 2.5 centimeters, which is conducted between 16 and 24 weeks of gestation. These findings or these reports have been validated in other studies, other meta-analysis done in 2018, which revealed that the vaginal progesterone was associated with of the duration of pregnancy in women with preterm labor, and it is highly beneficial in these cases. And I'm very sorry, please accept my apology that I may run out of my time, but I am always habituated to finish up my presentation by this immortal statement that knowledge looks like an endless puzzle. The more picture you put, and the more new question you will get. And we should be with ourselves and with us, and we should accept the other opinion, and we should adopt this dictum that the reality may be so complex that equally valid observation from different perspectives can appear to be contradictory. This person in this step as 3, but the other are interpreted as 4. Both might be correct. Okay. At the end of my presentation, thanks for all, and hoping good night for you. Thanks again.
Thank you very much, Professor Salah, for a beautiful presentation. We're really very happy and honored. Now, we have a few questions. There is a question from Dr. Fathallah Ura. He's asking about the oral use of micronized progesterone. Can we use vaginal micronized progesterone by us, through the oral route? And if so, what is the dose? Is it the same dose? Does it have any side effects if we use it this way?
Okay, thank you, Professor Hassan. Actually, the micronized progesterone can be used through many routes. Can be used either orally, vaginally, or even rectally. But the bioavailability differs according to the preferred route. The oral route, whatever it is, a minimal amount of it is being destroyed by the gastrointestinal tract. So the level of micronized progesterone will be lower than that if it is used vaginally. The highest serum level of micronized progesterone is actually reported after using the rectal route. But all of us know that the rectal route is somewhat inconvenient to many patients. So if you want to use it orally, please increase the scheduled dose more than the vaginal by about 100 milligram per day on the average. That means if you want to use 3 capsules per day vaginally, it's better 600 milligram. It's better to use it in a dose of 700 per day. And I think the new progesterone, which will be launched soon by the Tecno, will be very convenient. That's all of us know that all of the micronized progesterone available in the Egyptian market is 100 milligram. That's to use 2, for example, tablets or 2 capsules, but the 200 milligram will be very convenient, is to use 1 capsule instead of 2.
So orally will be 3 capsules a day? If we use orally.
Vaginally, the maximal dose is 600 milligram per day. If you want to use orally, increase it by 100 milligram per day. Simply, if you
but there is no side effect.
Definitely, increasing the dose of the oral micronized progesterone will increase its dose, will increase the side effects, unlike the vaginal. Because the oral micronized, whatever, it's undergo a process of first bypass within the liver, which will be converted into some metabolites, which will cause side effects. This is unlike the vaginal route, which undergo a process of first bypass within the uterus itself.
Of course, yes. Somebody is asking about the can we use vaginal progesterone in threatened miscarriage, threatened abortion?
Yes. Yes, it's the ideal route for progesterone, either in women with threatened miscarriage presenting with bleeding or pain, or even in women with recurrent early pregnancy loss. The best route is the vaginal. All studies speaking about the vaginal micronized progesterone, not about the oral micronized progesterone. So it's completely safe. Don't worry that if she is suffering of bleeding, okay, it's not a problem to use a vaginal micronized progesterone.
Okay, another question is about the relation between the dose and the body mass. If a female has a low body mass index, is it safe to use progesterone in pregnancy?
During pregnancy, you mean?
She has a low body mass index. She's slim. She's not very heavy.
Yes.
She's going.
Yes, actually, there was no study which calculated the amount of progesterone according to the body mass index. The dose of progesterone is calculated just empirically. In IVF cycle, you are in it for a dose between 400 and 600, but during pregnancy, the maximal dose which is necessary is 400 milligram per day.
Okay. A question about anemia. If a female with anemia, does she need progesterone supplementation during her pregnancy? I don't know if there's a relation there. Yeah, there's no harm of using it, is it?
There is no relation, absolutely. There is no relation between progesterone and anemia.
Okay. There is another question. Should we measure the progesterone during luteal phase support in IVF?
I think I have answered this question in more than one slide. And in Egypt, I think...
Should be measured routinely. I mean, should we, if we do IVF, then every time we should use? You should measure.
Yes, it's yeah. In Europe and USA, the vast majority of centers measure the serum progesterone routinely, because if it is low, you should increase the amount of progesterone.
When should you use it then? When should you measure it then?
You have, there are no standardizing time, but the high level IVF centers measure it once in the early luteal phase and once at the middle luteal phase. So in the early luteal phase, after 2 or 3 days after embryo transfer, if it is less than 20 nanogram, please increase the amount or the dose of progesterone. In the middle luteal phase, if it is less than 40, please increase your amount of progesterone.
Excellent.
But I think, I don't know whether a professor, I want to hear from you, whether the IVF centers in Egypt are applying this policy or not, in the routine measurement of progesterone in the luteal phase.
We personally, we don't measure the progesterone because the patients go away, and but anyway, but I think it's a good idea. I think we should start measuring the progesterone according to your recommendations. Yes, it could be a good policy to measure it 3 days after embryo transfer, and then again in the middle luteal phase, and measure it. Actually, we have a paper a long time ago in fertility and sterility on the level, the threshold of progesterone in the mid luteal phase pregnancies, and nobody less than 20 nanogram per milliliter if you want the pregnancy to continue, it should be at least 20 nanogram per milliliter in the mid luteal phase, but this was not in IVF patients. Okay,
yes.
another
I'm sorry, Professor Hassan, I have a comment before closing this question. I think I have presented this lecture a couple of months ago, and one of my colleagues, which is famous in IVF, was habituated to use an intramuscular progesterone. Okay, but after seeing this presentation and hear the concept that too high progesterone may impair the process of implantation, he shifted towards the decreasing the amount of progesterone, and he used vaginal progesterone, and he reported to me that yes, the pregnancy rate is increased markedly due to decreasing the amount of progesterone.
Yes, I think that's a very good answer. Yeah. There's another question. There are 2 randomized studies. One of them is by Professor Abulgar's group, is that if you stop progesterone before 12 weeks of pregnancy, the live birth rate is not changed, but there are bleeding episodes which make the lady a little bit anxious. So what is your experience, at least in this matter?
Yes, sure. I have read this article by our great Prof. Abulgar. And actually, I don't know what is the reason behind the use or the occurrence of spotting or bleeding. Okay, and whether these pregnancies which has suffered of bleeding, whether they continued or they underwent abortion, they reported that only the bleeding or the spotting increased. But even that, yes.
Yeah, but the live birth rate continued. There was no effect on live birth rate.
The same.
Yeah, but they only had spotting. Maybe, I mean, it's one study. They have 2 studies actually, but they are not sufficient.
Yes, not sufficient. And yes, and I think our great professor, you know that there are some formulas of progesterone, if it is used vaginally, it may be associated with a higher rate of spotting than in others. That might be a possible explanation.
Yes, could be. Yeah, there are many questions, but for the sake of time, anyway, can we give micronized progesterone in frozen embryo transfer cycles? And if so, when should we start?
Yes, I think in my presentation I mentioned that I will discuss this topic because it is different. The frozen cycle is different from the stimulated cycle. In frozen cycle, you need to initiate luteal phase from the start. And we have two large schools, the European school and the American school. The American school use a highly condensed protocol consisting of intramuscular progesterone together with estradiol together with a low amount of HCG. So in frozen cycle, it is stated that it is better to use intramuscular because it is associated with a higher serum level than the vaginal micronizing. So the situation is completely different. I didn't read a study which preferred the vaginal progesterone or the vaginal micronizing over an intramuscular in frozen cycles. But I think here in Egypt, the vast majority uses a combination of both intramuscular and micronized vaginal progesterone in order to increase the convenience, because 2 injections of intramuscular are too inconvenient for the patient. So the vast majority use, for example, 1 capsule at the morning and 1 intramuscular injection at the night.
Yeah, thank you very much. And I know you didn't discuss everything, but people are asking, can you use it in abnormal uterine bleeding? I mean, for like any other progesterone, it's more physiologic, it's easily absorbed, and so on.
Yes, I think we should encourage Tecno to arrange a meeting about the comprehensive use of progesterone. It has many other uses, but you know that our professor, this is only concerned with contraception and reproduction.
Yeah, I know your talk has been very comprehensive, and you said from the beginning it's a very vast talk, but it's a beautiful talk, and thank you very much. I think we, for the sake of time, we have to stop here, and to thank you very much for a beautiful presentation as always, and waiting for the next one, inshallah. And we thank Tecno, and I hand my microphone and my camera to the Tecno people, and thank you very much.
Before going, please, I just have a comment. أنا يكفيني النهارده أنا شفت حضرتك بجد، يعني حضرتك وحشني كتير جدا، فبنشكر تكنو إن جابت لنا شخصية زي الدكتور حسن بيه سلام. It's the star of IVF in Egypt. ده حقه، ماشي. فمتشكرين جدا إن احنا شفنا حضرتك النهارده. شكرا تكنو.
شرف لي صراحة، ميرسي على كلامك الجميل. Thank you very much. And to Tecno.
Thanks everyone for your attendance today. Special thanks goes for Professor Ali Obba joining us today from UK. Thank you for the rich content and the presentation for the role of Drostperinone ethinyl estradiol in family planning. Thanks for Professor Salah Rashid and Professor Hassan Salem. It's an honor having you all today in our webinar. Thanks everyone, and see you soon in another webinar, inshallah. Thank you.